Okay. I can't tell my visions. Is it in focus? Mostly. Yes. Okay, good. Is it in focus? Okay, yes. Is that in focus? Okay, good. So welcome, everyone. Glad to have you here. I'm Carol Runyon, professor in epidemiology and director of the program for injury prevention education research here in the School of Public Health. And we're pleased to be sponsoring this seminar today. This may be our last in the well, it is the last in the semester. We may have some more over the summer. Stay tuned. But I was made aware of a possible interest, and I'll send a flyer around as well. It's taking place next week. It's not sponsored by us, but by friends in the School of Pharmacy on opioid awareness and naloxone training. I'll send this around in case any of you are interested. I can't see it when I put on the board, but just wanted you to be aware. So today I'm pleased that our colleague, Dr. Ingrid Binswanger, is with us. Ingrid, as many of you know, well, let me just ask before I introduce her, how many of you are from this campus? From Kaiser? You didn't bring any entourage with you? From State Health Department or other agencies? Great, so it's a nice mix. So Ingrid is both on this campus and at Kaiser, where she's senior investigator in the Institute for Health Research, and also an attending physician who works with chemical dependency treatment services. She also holds an associate professor position here in the Department of Internal Medicine, Division of General Internal Medicine. She did her medical training at UC Berkeley, residency at UCSF, and then was a fellow in the Robert Wood Johnson Clinical Scholars Program at University of Washington, where she got her MPH. Right?
That's
right. Did I get that right?
Yeah. Yeah.
So she's given seminars for us before, and we're pleased to have her back for an update.
Yeah. Sounds good. Thank you so much. So let's see. So this is slightly awkward because I'm going to be trying to get this thing to advance from here. So I'm delighted to be here. I just want to thank some of our funders. We have some funding from CDC to do some of our work on opioid tapering, and also some funding from NIDA to do the trial that I'll be talking a little bit about. And I always feel like this slide, the funding slide always obfuscates the fact that there are many unfunded studies that we could apply for in this as well. But we've been pleased to have some funding recently in this area. I also want to thank my collaborator, Jason Glantz, who's worked with me on a lot of these projects. And I will be sharing something that's not, for anyone who's in medicine, that's not FDA approved, a device for naloxone administration. So I just mentioned that. We have a large team of people that have been helping with this work. I just wanted to thank them from the beginning. Many of them are based at Kaiser, and a number of them are also based at Denver Health. So I thought what I would do today is talk a little bit about the current scope of the opioid epidemic, although I'm pretty sure that pretty much anyone in this room can probably repeat exactly what I'm going to say, and maybe even better. But I'll just briefly touch on what's been going on recently. And then I'm going to talk about four approaches that we've used to try to understand and address the epidemic in its sort of evolution from prescription opioids to heroin and now illicitly manufactured fentanyl. One of them is a qualitative study. Another one is a predictive modeling study. These have both been recently published. Actually, one was published a couple years ago. And then I'll talk about a randomized trial that we have underway at Kaiser now, and also another ancillary trial that's at Denver Health. And then I'll talk about some of our epidemiologic work to try to look at the potential impact of tapering opioids on heroin overdose, and that I'll just briefly touch on a preliminary study that we're doing for that. That's a nested use control study. and then hopefully some time to discuss future direction and what needs to happen now, and I welcome your input and thoughts about that. So does anyone have any initial thoughts to share about what's going on in the opioid epidemic? What's going on? What's been going on? Any thoughts? Susan. Students, maybe? JK knows this well. Why don't you tell us?
$100 billion just got proposed for funding various approaches to opioids, and then a little bit more for education. They're pretty big.
So there's been a lot of funding interest in the topic, and really that's been driven by the fact that overdose now exceeds HIV at the peak of the epidemic in terms of the deaths it's causing per year. So, in the initial late 1990s, early 2000, we saw a dramatic increase in prescription opioid pain reliever overdoses. This was driven by marketing, by some obfuscation of data, by limited evidence about management of chronic pain and alternatives to pain, a number of factors. But basically, when I was a resident in the late 1990s, we were taught that it was safe to treat chronic pain with opioids and that this would not result in addiction if patients truly had pain. And if anything, we were discouraged from undertreating pain. So we were very concerned about pain as the predominant feature and that opioids could be safely used. So that in part led to the prescription opioid epidemic that we've been seeing. And then more recently, we've been seeing dramatic increases in deaths from heroin and illicitly manufactured fentanyl and other fentanyl analogs. And this just goes until 2015, but it's continued to rise, obviously in 2016 and 17. This is some more recent data showing synthetic opioids at the top. That's predominantly fentanyl that's illicitly manufactured. That's the blue bar. Heroin is continuing to rise. Actually, pharmaceutical opioid-related deaths are also continuing to rise, and then we've seen an increase in cocaine-related deaths as well recently. So this has been a very rapidly evolving epidemic. We started with a lot of focus on reducing prescribing for chronic pain. And so we started off by doing some research that really was based predominantly qualitative. We did a fair number of these studies in Kaiser Permanente, Colorado, which is an integrated health plan and delivery system. Most people here are probably familiar with it. We serve about 680,000 members, and it's really great for epidemiologic research because it's a denominated population. And especially with drug use-related outcomes, we don't lose as much follow-up. So it has implications for sort of being able to do more rigorous epidemiologic studies, because we still have some loss to follow-up, because obviously as people develop opioid use disorders, they're at risk for losing insurance and their jobs and their insurance, and then we do lose them to follow-up. So we've been trying to address some of those problems. But in terms of a source population to conduct some of these studies, this is where we've been doing that. So one of the approaches that's been thought of to address this epidemic is Naloxone or Narcan. This is the Narcan nasal spray that was recently approved for administration by lay bystanders to individuals at risk for who have an overdose. And as most of you probably already know, this is a very efficacious medication. It does, in most cases, reverse an overdose if you give sufficient doses. Although with some of the high-potency fentanyl that's available, this might require a drip or very high, many doses. It traditionally was administered by first responders and other medical personnel to reverse opioid-induced respiratory depression, which is the hallmark of an overdose. But now it's been sort of moving into clinical settings to try to give it to people who are at risk for an overdose. It doesn't really have any abuse potential, although it can precipitate withdrawal, and people obviously can resume having pain after they're administered this immediately. So there are some potential for issues after the administration of naloxone.
Ingrid, can I ask you two quick questions? Will insurance companies pay for prescription for bystander, keep around for that purpose? And how much they'll cost?
Yeah, so let me go through some of the pricing issues here. And so I'll just tell you that at Kaiser, we will cover it for an individual who, say, has a family member who's using opioids and they want to have it around. We will cover it in that scenario. I can't speak to all insurance companies, but we certainly do. We also have a standing order that we implemented so that anyone can pick it up at any of our pharmacies if they're a member, and they don't need a prescription for it. So they can just walk up and ask for it. They don't need to go see their primary care physician to ask for it. So this is sort of where it started, was in harm reduction, places like Harm Reduction Action Center or other kinds of community-based organizations that serve people who use heroin, where they basically gave out kits, naloxone kits, for people who inject drugs so that people could give naloxone to each other in the event of an overdose emergency. And this makes a lot of sense because these individuals don't necessarily want to call 911. They're concerned about the police coming, and they witness a lot of overdoses. So but obviously for somebody who has chronic pain and is taking opioids, this is very complicated because they're not used to using syringes. And even for physicians to try to put this together can be a little complicated. It's normally something a nurse would do, sort of putting this kind of kit together. So then the FDA approved Evzio, which is a very fancy delivery device for the same generic substance, which is naloxone. And this can cost upwards of $3,000 to $4,000. I don't know if anybody knows how much it costs currently in the UC system, but it's extreme if it's available even here, but it's very expensive. So obviously this is not something that insurance companies are happy to have on their formulary. And I think it's probably limited uptake. What's really nice about this device is it talks to you and it gives you instructions. It's very easy to use and reliable in an emergency, but it is very expensive. There's also an intranasal kit that was developed, also predominantly by community-based organizations. This is to deliver naloxone in the nose. There are issues here with the distribution of the naloxone. It's not FDA approved because there's some concern that that atomizer kit at the end will not adequately distribute the naloxone in the nares, especially if there's anything going on with your nose, like you've recently vomited or something else, there's any mucus in the nose. So there are some concerns about that device. FDA did approve the Narcan nasal spray. This is also expensive, not quite as expensive as Evzio, but it's currently around $700 or $800. Unless anybody knows anything.
It's like
$125
cash.
Oh yeah, this one is the one. Which one?
It's about $130.
This one's, yeah, that's right. I'm sorry. You're right. This one's the price has been rising, but it's somewhere around $160, at least depending on the system. So you're right, it's not $700. I don't know where I got that from. But it's still a little bit outside the price range probably of most individuals to buy with cash. And then if insurance covers it, it's going to be under your sort of regular co-payment. So those are sort of the options. So in terms of the initial study that we conducted in 2014 to 15, we wanted to find out at this point we wanted to really find out how would primary care providers respond to delivering or prescribing naloxone to patients who take opioids for pain. And so we did a qualitative study, and we really tried to learn about what are the knowledge, what are the attitudes, what are the beliefs about providing overdose prevention education in naloxone by primary care physician to patients who are taking opioids for pain. And also we talked to patients to try to find out what are the barriers and facilitators to them picking up naloxone and conducting, and basically getting it and using it at home. So we did 10 one-hour qualitative focus groups with medical staff, 56 of them in 3 different health systems, Denver Health, Kaiser, and University. And then we did 22 individual interviews with randomly selected patients who received 3 or more high-dose opioid prescriptions in the last 6 months. So these are people at relatively high risk in that they were all receiving more than 100 milligrams of morphine equivalents. Okay. And we used a behavioral theory to drive our focus groups and interview guide, and then we did inductive and deductive analysis of interview and focus group transcripts. So basically what we learned from these focus groups and interviews that really drove all of our subsequent research was, first of all, that physicians really wanted to know who they should prescribe this to. And this is in part driven by the cost issue, is that you can't really prescribe it to everybody who's either ever prescribed an opioid or who's even on chronic opioid therapy, just because the cost implications are pretty dramatic. So for health systems, I think there's some concern about how many people can we realistically get this to. And then I think physicians also wanted to know who they should give it to. They also wanted to know how can they communicate overdose risk and the need for naloxone to patients without offending them or making them feel sort of labeled as an addict. They basically didn't want patients to be offended when they brought this up with them. This is sort of a difficult conversation to have in primary care practice, and providers were sensitive to that. They were also worried about risk compensation, which is very common in pretty much everything we do in public health. Would people actually increase their risk behavior if they had this potentially life-saving device with them? Would they engage in take more opioids, be less cautious? And then finally, they were concerned about adverse events in the populations they treat in primary care. So these are often older patients. They have multiple comorbidities, diabetes, hypertension, COPD. Is there any possibility that if you suddenly throw one of those patients who's taking chronic opioids into withdrawal, that you might precipitate an MI or some other adverse event, especially if they're not really having an overdose? Could somebody in the family really recognize an overdose, give it to the right person, and then how would you manage it if that person suddenly is in withdrawal, vomiting and in a lot of pain? So that was some of the concerns that providers had about the medication. And then, so this is a couple examples. The naloxone might give them permission to play with their dose and, try and get high. Another thing, so I would want there to be guidelines in place, institutionally sanctioned, as to how to risk stratify patients and what the appropriate prescribing guidelines would be. So then the patients, they basically said, we never really knew that there was a problem with opioids. This was, of course, several years ago. We didn't necessarily know that it could cause me to have an overdose. Again, this is a few years ago, so the context has changed now. They didn't necessarily know about naloxone. They didn't see themselves at risk, and I think this is one of the principal issues we've been trying to address in some of our work since then. So even if they'd had prior near overdose or even true overdose events, they didn't think that they were at risk. They didn't think they needed naloxone. They'd had many prior experiences that were very negative with open disclosure of risk behaviors. So if they'd shared with their physician that they drank alcohol and they were on opioids, they were concerned that the physician might then taper them off of the opioids. So there was a bit of a conflict in terms of how much they shared with their physicians around this topic area. And then finally, they were really worried that there might be negative consequences if they request naloxone or if it's used on them. And this is where they're worried that, they could lose access to their medications, they could be tapered or cut off altogether suddenly. So we learned a lot from these interviews. This is one of the examples. I think Joe, who's here, and Susan have already heard this before, but the interviewer says, do you think it might be helpful to have it for yourself? The respondent says, no. You don't think naloxone would be helpful for you to have around? No. Why is that? Because I don't need it. And then the patient says, the same respondent a little later in the interview says, well, at one point I was taking a good chunk of morphine during the day, and well, to be honest with you, I burned all kinds of holes in the carpet from smoking cigarettes, and I'd go like this, and the patient demonstrated that they were nodding off. Nodding off, or yeah, and that was when I was taking too much. So this was a patient who adamantly denied that they needed naloxone, but actually had a lot of risk. And then this is another patient who said, I was totally honest before and I got screwed. If I agreed to have this naloxone in my house and God forbid something happened and I had to use it or someone had to give it to me or whatever, I don't think I'd come back and tell my doctor that I had to use it, just because of the way that everything's been treated. I think that the doctors need to be a little more forthcoming about what they're doing, and they need to let a patient know that there will be no consequences, because I can just hear them now, you OD'd, we told you this was going to happen. You had to use this, whatever that drug is, and then all the repercussion coming from it. I can just hear it all now, and I wouldn't be very forthcoming about it. So this was one of the reasons that patients were reluctant to even pick up naloxone. So basically, these interviews led to a series of subsequent studies that we've been conducting. And we basically we developed a predictive model for use in primary care to respond to the question of who to prescribe to. We then are conducting a pragmatic randomized trial of direct patient outreach with a video to address questions of does it influence risk behavior and patients reporting limited knowledge and risk perception. We then also are doing a naloxone adverse event self-controlled study to respond to the questions about whether it could cause adverse events. And then to respond to the concerns about tapering, we're doing a tapering study that's an epidemiologic study. So I'll walk you through a couple of those now. So in terms of does anyone have any questions so far on that qualitative piece before I move on? Okay. So the next study we did was really to try to figure out who to prescribe. And I've already alluded to this. You know, there's some questions, should we be giving it to anybody who's exposed to an opioid, naloxone? Regardless of the setting, you know, is it urgent care, if it's emergency department, if it's after surgery, if it's after a sprained ankle, or if it's chronic opioid therapy. Or should we wait for patients to come and ask for it? So, you know, they come to the pharmacy and pick it up under a standing order, they know they're at risk and they get it. Or should we do risk-based provision of naloxone? And I don't know if anybody here has any opinions about this. I'd be curious to know. Is there anybody here who has an opinion about what we should do?
I think we just need to flood everybody with Narcan because there really are no downsides to it that we know of. We know that fentanyl's coming. We're woefully underprepared for that.
Yeah.
So I think we should be handing it out. And it's $1.
And how about you?
I mean, this is anecdotal, and I don't like to be that way, but really when you tell the patients that this isn't necessarily for you, but this is to accompany your prescription. If your kids get a hold of it, someone comes over and they take it, this is so you can save their life too. Opioid overdoses have increased despite prescriptions going down, and you want to be able to save people's lives if something happens. So even if it's by mistake or on purpose, that's there to save your life or their life. So that's when usually patients are more accepting of it, and it's not, hey, I'm calling you an addict. I'm saying that these medications can be dangerous for anybody. So. Yeah,
and I agree. I think there's a lot of ways that we can phrase this conversation so that people are more receptive to it. So at the time that we did this, we were really under the assumption that distributing naloxone would have to be risk-based, especially in patients with chronic pain on opioids. So we basically conducted a predictive model study. This was really in contrast of all of the very nice epidemiologic work that's been done that was designed to try to figure out what is causing overdoses in people who are on chronic opioid therapy. They've shown things like increasing opioid dose is associated, long-acting formulations are associated, combinations of opioids and benzodiazepines are associated, and opioids prescribed by multiple clinicians are associated. So those are all important risk factors. What we were really interested in is, can we predict who's going to have an event over the coming 2 years? And we chose 2 years because we knew that the expiry date on naloxone is 2 years out, generally on average. And so we figured if somebody prescribes their patient naloxone, that patient should, in theory, have the naloxone around for about 2 years. So we wanted to know the 2-year risk. So anyone have any thoughts about, and I know we have a couple of primary care clinicians here, about what you need for a predictive model to actually be used in practice? Yeah.
The number of variables.
Yeah, so there have been studies, and Joe has sent some of these to me, and there have been studies that have done predictive models for this kind of event where they have like 25 or numerous variables. And unless that can be automated, that's very difficult for a primary care doctor to do in practice. So that's one of the features. Any other features of a predictive model that you think are important?
During the 2 years, how many events you expect to see in average?
Yeah, so you need to follow it. You're saying you need to follow for 2 years and make sure that there's enough events to power a study for this. Yeah. So that's an issue. So we actually did this in our large health system where we would have enough events. But that is an issue. Obviously we couldn't do 30-day outcomes because we didn't have enough power.
So during the 2 years, it's possible that you can observe more than one event?
Yes, that's possible. We stopped at the first event in this modeling, but you can have more than one event.
Ideally, it would be patient-reported data through a portal or Quick Welcome or something like that, and or some kind of healthcare assistant, MA, being able to gather that data and not leave it up to the primary care doctor.
Yeah, so we were actually even more ambitious than that. Because we thought, the MAs aren't going to do it. We were actually even more ambitious than that because we were like, we don't believe the MAs will do a questionnaire. We don't believe the primary care provider is going to do the questionnaire. We're going to use just electronically available data in the EHR so that we could potentially do it that way, so that it could potentially get automated. So, but it's a good idea, make it really super simple, something that a non-clinician could administer the very first person you see in clinic. Did you have a thought?
Yeah, I was going to add that you wanted to provide information that is actionable at the point of care, is going to change your recommendation to your patient. And so if the recommendation is that everybody should get it or that nobody should get it, providers probably pay less attention to it over time.
Mm-hmm.
I think you want it to both be actionable but also be perceived as actionable. So when docs are seeing it, they feel like it is helping them to do the right thing. Now that's maybe somewhat out of your control, what they're going to perceive when they see it, but ideally it helps them feel like it is sort of a tool they want to learn and stick with and keep putting to use when they see the patient.
Yeah, I totally agree. So we want it to be actionable and we want it to be clear what they should do as a result. So that's great. Yeah.
Because this is a rather benign intervention, I would make my model more permissive versus sending this person to surgery or doing some sort of invasive process on them. I would want to.
I totally agree.
Whatever.
Yeah, no, it's great. That's exactly one of the other important things is that this is a benign intervention. We can give it to lots of people who are never going to have the event. So it doesn't have to be, but if you use then the same predictive model for another intervention, that's may have negative consequences like rapid tapering of opioids or something like that, it might not be the appropriate model. So we really directed this to naloxone, and that's how we set our cut points. So I'm not going to go into too much detail. You guys have already basically summarized all of these points. The only other one that you didn't mention is generalizable. So we actually developed this in Kaiser, and then we internally validated it, and then we also validated it at Denver Health. It's a very different population, and normally you try to validate a predictive model in a relatively similar population, but we chose Denver Health. And it probably did impact the performance a little bit. It's not as perfect as it would have been in another Kaiser, but it was still relatively good at Denver Health. So we built it. I think I already mentioned all of this. So we used some of the predictors that are known in the literature. I think the one other element is that we chose predictors that didn't necessarily have to be causally related to the overdose. So whereas the other risk factor literature really tries to find things that might actually have a causal association. I don't know whether tobacco has a causal link to overdose, but we included it in the model. So this was our design. We basically took we followed our cohort for anyone who had 3 opioid prescriptions in 90 days. We took the 3rd opioid prescription as our index date. We looked backwards over a year to look for potential diagnoses and other factors that might be associated with overdose. And then we followed people forward for 2 years to look for an overdose event. So that was basically the design. And our model ended up with 5 variables. We tried to be parsimonious about it. The reviewers resisted a lot of this. They kept saying, you have to add these more things. And we were like, no, we don't want to add any more. So we had age, which was a quadratic relationship. We had a mental health diagnosis as basically associated with a 3-fold increased risk. Substance use diagnosis associated with 3.5-fold increased risk. Tobacco, 1.5-fold increased risk, and then either being on a long-acting or extended-release opioid. So any of those, and interestingly, dose, which has been the main focus of a lot of efforts, did not end up in our model, and I think this is because we were looking forward and dose tends to change over time. So the dose you're on today may not predict your overdose a year from today. So we really didn't emphasize dose. This model did not emphasize dose.
Why did you not put in their previous overdose?
There's very few people who've had a previous overdose.
Okay.
So it wouldn't have been predictive. it's such a tiny,
Okay.
I mean,
It didn't
it's a
happen.
it's a high risk among people who've had it, but in terms of a thing that you would use in primary care,
Those patients.
it really didn't. We couldn't. There was not enough numbers to include that. Yeah.
Did dose vary enough with like mental health diagnosis or age such that it dropped out of the model?
I mean, that's another possibility is that it, doses. I mean, we did
Doses
look
explains
for
all these other
we did look for those kinds of, excessive collinearity, but I don't think that wasn't it. We looked at it a number of ways. So.
And Ingrid, did you include alcohol under substance abuse? Or?
Yes, so it could be an alcohol use disorder or a drug use
But
disorder.
not just alcohol.
But not
use
tobacco.
itself.
Not just alcohol. It has to be a diagnosis of a use disorder. Yes.
It could be alcohol stuff.
What's the age range?
The age range, it was, that's a great question. I can't remember exactly. It was pretty wide, but I would say it's skewed towards the older ages because it's folks who are on chronic opioid therapy. And I want to say the mean age was around 55. Maybe even a little bit higher than that. It's an older population who is on chronic opioids.
Were there any gender and age interactions, or?
I don't remember there being any gender and age interactions, but I would, you would expect in a heroin population there may be a gender age interaction, but in this case this was people on chronic opioid therapy, but we didn't see anything specifically. So we basically developed, this is a little complicated, much more complicated than I'd like it to be, but because age is quadratic, we have this scoring system, and basically we developed a way that you could score this and calculate what your risk. And our thought was that people who were either medium or high risk would probably be appropriate for receiving naloxone. And what I liked about this is that it had some clinical I felt happy that what this model did do is that almost anybody with a substance use disorder who's on chronic opioids under our model would get naloxone, and that just sort of had face validity to me. As a clinician, and I was just happy that it worked out that way in our model. So, I think, but otherwise, so that's basically how you would calculate it. And now what we're doing is trying to figure out how to integrate it into Epic. Right now we have it as sort of this survey thing, and then it calculates your score automatically and tells you whether to prescribe naloxone. But what we'd like to do is seamlessly integrate it into Epic so that providers could have this at the point of care. Okay, so in conclusion, we developed a model. I think there's still room for debate in the scientific community or folks and clinician community about what the right cut point should be for naloxone distribution. I really don't know the answer, and I wouldn't be the one to presume to know the answer. And whether it should be universal or whether it should be everybody high and medium risk, but that's the idea behind this. And I think the interventions, I think you already made the point that the interventions that you do with such a risk score really depend on the risks and benefits of the intervention itself. And the financial implications for a health system, yeah. I'll tell you that our health system was not excited about giving naloxone to everybody. They did make it available under a standing order, but that's really self-selection. That's not pushing it out to everybody. Okay, so now I'll turn to our trial that we've started. I've been really excited about this. We've actually recruited 224 people at both our sites right now, across our sites. So this is super exciting for me to actually do a real intervention. So our goal here was to do direct patient outreach to patients on chronic opioid therapy outside of the primary care office, because I sort of share some skepticism that this is going to happen in primary care, the naloxone prescribing. And we ended up settling on outreaching them with an animated online video that incorporated a lot of what we learned from our qualitative interviews about how the resistances patients have about naloxone and the kind of information that they need about overdosing naloxone. So I'm just going to show you the very beginning of our video. I won't go through the whole thing, but... How do I do this?
After the accident, I had a lot of pain in my back and neck that didn't get better over time. This made it hard to do things I enjoyed, like biking and running. I tried a lot of ways to help me feel physically better.
Like 50 million other Americans, Jane has chronic pain.
Now I take prescription medicine. It's an opioid pain medicine like these others. It helps me a lot, but there are things I don't like about it. My medicine makes me itchy. And it makes me constipated.
Jane, hurry up, we're late.
Jane describes some unpleasant side effects of opioids, but there's another possible side effect that is much more serious. It's called an overdose. Deaths are more common from overdose than car accidents. An overdose emergency is when you stop breathing due to opioid medicines. Sometimes it's not easy to know if someone is having an overdose. Here are some of the signs. Slow, shallow, or stop breathing. Unusual snoring or gurgling sound. Being unconscious. Not responding to urine or touch. Lips or hands turning blue or gray. Pupils of the eyes are very small. If you see some of these signs, it probably is not overdose, and you should call 911 right away. Chest pain. Weakness on one side of the body. Seizure. Agitated behavior. Rapid heartbeat.
Overdose? What do you mean? I don't take too many pills. I also don't use drugs.
Overdose can happen for many reasons. It can happen by accident. A child could be curious about your medicine, or think your medicine is candy, or someone could steal your medicine. This is why I tell all my patients to walk with their medicine. I also tell them to get Naloxone, medicine that can reverse an accidental overdose. Jane got her Naloxone from the pharmacy.
So that's the, I'm going to move on because of time, but that's the basic gist of it. Then we actually tell the story that she drank too much alcohol, she went on a long-acting opioid or something. I think that was what the story was. And then she has an overdose. Her husband finds her. He reverses it with Naloxone, and then they go to the hospital. So we sort of walk them through all of the steps of what you would do in an emergency. Then she goes to the hospital. Then she realizes that she needs to safely store her medicine, and she goes back and she gets a refill at the pharmacy. So that's basically what we did to try to engage patients. We had to keep this in 6 minutes. It started out at 12 minutes, and it had 3 different people, and it was very complex. And we basically narrowed it to like really try to key in on the most essential points.
So do you show this during the clinical encounter?
So actually what we're doing is we're doing direct patient outreach. So anybody who's on 3 or more opioid prescriptions, anyone who meets the definition for chronic opioid therapy, which is 3 or more opioid prescriptions, we are outreaching them in the pharmacy. They've had them dispensed in a 90-day period. We're outreaching to them by email, text, letter, and we send them a link to the video. So they can watch it in their own homes. And then they can share it with their loved ones or caregivers as well. So we have a link that also you can share with your caregiver. And then we're trying to answer these questions that were really directly derived from what the providers were worried about. Does it impact risk behavior? Does it improve knowledge about overdose and naloxone? Because maybe this won't work. Does it improve naloxone uptake? Does it affect fatal and non-fatal overdose rates? Does it impact somebody's dose? Maybe they suddenly decide to stop taking opioids. I find that highly doubtful. And then does it have any change in pain intensity scores if they do change their opioid dose? So that's what we're trying to do. And the study design is basically a pragmatic trial. We've implemented the standing orders. We outreach to the people on chronic opioid therapy. We do an online consent. They get randomized to the Naloxone Navigator or not. And then we look at their outcomes by electronic surveys and also by EHR data. So we never actually have to speak to the patient or meet them in clinic or any of those things. It's all completely electronic.
How do you know if they watch the video?
We actually can tell on the back end how far they've gotten through, because if they want to get their gift card, they actually have to have watched the video.
Oh, gotcha.
So at the end of randomization, you either go get your gift card or you watch the video, and then you can get your your compensation for being in the study. Once you finish your surveys too. Yeah.
Is the survey deployed at the end of the video or later after you watch it?
So the survey, most of the survey is before the video because we have to give it to both groups. There's one item of the survey that's the knowledge that comes after the video for the intervention arm, but comes after the other surveys for the control arm. So technically putting this all together was actually extremely complicated, and I'm just so grateful to our staff because they have done similar things in other areas and they've been able to, even producing the video, all of these pieces, getting the professional actors to do the voiceovers, all of that stuff is really thanks to the staff because it's not stuff that I would have known how to do.
So are you studying just that video? So the Naloxone Navigator is the video plus Naloxone, or just the
Just the video, and then we hope that they go. But this context is that to even do the trial, we implementing standing orders, so they don't have to call their physicians to get the medication.
So
they just go to the
groups
pharmacy.
had a Naloxone prescription at home.
They didn't need a prescription.
Or they had the ability to take Naloxone home.
Both groups could go to the pharmacy and pick it up. Yeah, and that's part of what we tried to explain in the video.
Was it a standing order through CDPHE or was it an internal Kaiser?
Internal Kaiser standing order that we implemented. That took 2.5 years to implement.
And how knowledgeable, so this has been one of my issues, is going to a pharmacist and asking for naloxone is not 100%.
Yeah.
So how knowledgeable were your pharmacists about naloxone?
Well, that's part of what took a long time. We've done multiple trainings with them, and of course the staff turns over in the pharmacy, the techs.
Yeah.
And we actually, at Denver Health, we're doing a different kind of intervention. We're doing what's called co-dispensing, where the pharmacist actually gives the patient naloxone with their opioid, and it's a different design completely. It's a pharmacy randomized trial. But I think we do worry that patients will show up. We did a lot of work with operations. This was a study designed with operations at Kaiser, and we did a lot of work with pharmacy to try to make sure that their staff were ready to receive people. But we will be doing some qualitative interviews after the trial's over to make sure that patients felt like they could get it. And we are asking questions about what happened to them if they tried to go get it. Because I think that is a big barrier. Like in theory, a lot of pharmacies have standing orders, but when a patient actually goes to try to get it, I think in many instances they can't get it.
It has to be persistent.
Yeah, that makes a lot of sense. Yeah. So, but if anybody does know of any problems at Kaiser getting naloxone, please come tell me. I want to know. So we've sort of, tried to go and do it ourselves. But okay, so the last thing I'm going to mention is just our work that we've been trying to start on tapering. So there have been many guidelines and policies to try to get physicians to rein in their prescribing, which makes a lot of sense, and to monitor and select patients, to do risk mitigation, risk stratification about who they prescribe opioids to. And Medicaid has implemented very strong, not very, but reasonably strong policies within Colorado about this, and has seen decreases in their opioid prescribing. But CDC guidelines also do suggest that in some instances you are going to want to taper a patient, especially if the risks are not outweighed by the benefits, and in certain contexts. But actually, Joe has done some of this research about, tapering is actually difficult. I think it can be done, but it's difficult, and most clinicians know this. It's really not clear how to do it exactly. It can take a long time. It can lead to withdrawal symptoms and increased pain. And so this is not a straightforward endeavor. And then, of course, there have been a lot of questions recently about with the ecologic trends that we're seeing nationally, does it also lead to heroin use? Do people come off of their prescribed opioids and then go seek illicit opioids, including heroin, to treat their pain and withdrawal symptoms? So that's the topic of some of the work that we've been funded by the CDC to do now. So this is an observational study, and we want to look at both intended and unintended effects of opioid tapering on both opioid pain reliever overdose and on heroin use and overdose. But when we got this funding, we suddenly realized that we actually didn't know for sure even that prescription opioids were associated with future heroin use, so prescribed opioids. We know that lots of people who use heroin have a history of using illicit opioids and may have also gotten exposed to opioids in the healthcare setting. We just didn't know how much of an association it was and basically how strong an association it is. So we basically took a step back to try to look first at is prescribing itself associated with heroin overdose? It's certainly associated with pharmaceutical opioid overdose, but what about heroin overdose? So this is where we used sort of a classic nested case control study. We have a cohort, we follow them over time. We identify the outcome of interest, which is heroin overdose. We go in the medical record, we confirm that outcome, and then we match them to somebody by age and gender and insurance status, look back and see if they had that exposure to prescription opioids going backwards. So these are a couple examples of what our design looks like. So this is the first findings that we have based on this case control study. And basically we did show, yes, indeed, heroin does appear to be associated with prescription opioids do appear to be associated with future heroin overdose. It's almost a 3-fold increased risk, but there are other very important factors, like tobacco use is actually considerably more strongly associated, 6-fold increased risk. Mental health diagnosis also is associated with an increased risk, and race ethnicity are as well, especially white race ethnicity or not reported race and ethnicity. So this is just interesting for us to put it into context in terms of exposure to prescription opioid and future heroin use.
Ingrid,
yeah.
Why did you use heroin overdose as your outcome instead of heroin use or?
So heroin use is going to be, heroin overdose is very well defined by ICD codes and by medical record review. Heroin use is a morass of meths in the electronic health record. And so that's what we're trying to sort through now is how to identify heroin use in the electronic health record and the timing of the use. And then there's, of course, also issues like patients have evidence of heroin use in lab values but didn't necessarily tell their providers that they were using heroin. So there's even issues with confirming heroin use in the electronic, in the written notes.
Yeah.
So we started with the easier thing. So, we did find a strong association between receipt of any opioid prescription. This wasn't even chronic, this is any, and the risk of future heroin overdose. So it may be the sequelae of prescribing opioids eventually in some patients, but it's really not clear that it's causal because then when we went back in the records, we did find that in about 1/3 of the cases, the heroin use appeared to have predated, just like you're saying, the prescription. And of course, a lot of these patients are not on chronic opioid therapy, so we can't even look at tapering necessarily in this group. We need actually much larger numbers, including multiple sites, to look at tapering, because there's actually not that many patients who have a heroin overdose event who were on chronic opioid therapy, and then when you get to the number who were actually tapered, there's not going to be large numbers. We need at least 3 sites to probably do that study. So this has turned out to be a little bit more complicated than we had originally anticipated to answer this correctly. So I guess just to summarize, in terms of, and also sort of bring in some of our future directions, I think obviously addressing the opioid epidemic, CDC and everybody else says this, it requires a multi-pronged approach. Clinical, public health, criminal justice, just all kinds of different settings probably need to be involved. I think we do need some new tools that are very patient-centered and also provider-centered and even health system-centered to help reduce the risk. And these can include things like predictive models. Susan Calcaterra has also done some work on predictive modeling in this kind of context. And then I think it's helpful to do some direct patient outreach because there are limitations to what patients will share with their primary care providers. I think it's also important to really be skeptical about some of the interventions that initially seem very logical and just make sure we fully understand potential unintended consequences. And then I think we need to also think about now the evolution of the epidemic and how are we going to identify and intervene on people who are using heroin and illicitly manufactured fentanyl. Barbara and I have been talking about this, and we'll be hopefully doing some more work on trying to figure out how to outreach to that population, because that's a younger and harder to find population. And just from my treatment experience, young people using heroin are just much harder to engage in treatment. It's just harder. And so we have to try some new things to get that population engaged. So that's this. I'm happy to take questions or comments, thoughts. Yes.
So I'm
maybe say your name too. If I don't know you.
Alexis Ritzel. I'm the addiction psychiatrist with the department here. Work between Cedar and our outpatient psych clinic, supervising residents. So we're not directly prescribing opioids. We do Suboxone, but we prescribe a lot of benzodiazepines. So I was wondering if that was something looked at in any of your models, the co-prescribing, since we know that increases risk.
Yeah, and actually that's a good thought. Yeah, and I think we in the predictive modeling we did look at benzodiazepine prescriptions, and it didn't end up in our final model. It doesn't mean it's not associated, right, but it didn't end up in our final model. It's very predictive, but it's still an important risk factor. Yeah. So I think that makes a lot of sense to look at that pattern of prescribing.
CDC has it on their rough guidelines, co-prescribing benzodiazepines. As what should prompt a naloxone prescription.
As what should prompt a naloxone prescription. Yeah, that's a good. And I bet those patients would be captured in our model under mental health diagnoses, because most of them are probably going to also have a mental health diagnosis. So I'm not too worried about our model, because I think it'll encompass most patients on a benzodiazepine, unless they didn't get a mental health diagnosis. But I think that'd be very unusual, that they be prescribed benzos without a mental health diagnosis, anxiety or anything.
Surgeons love to use it for spasms.
Spasm, that's a good thought, yeah.
Epilepsy?
Yes, and it's like restless legs,
that's a good thought.
It's not first line for anything except for benzo or alcohol withdrawal and anesthesia induction, but it's way overprescribed. And there's a study out now from North Carolina, y'all are actually probably familiar with it, but the Weld County data was over 2 million patients, but it showed exactly a 10-fold increase in opioid overdose with concomitant benzos. So, and when you hear in the news, like Prince overdose, he had opioids, and it's like, alcohol benzos. Yeah. So you always hear that. Usually it's not as many as just the pure opioid overdose, but it's the mixing.
Mixing, yeah. And I think that's a good point. I mean, the other point you bring up is that our predictive model was really designed for chronic opioid therapy. I mean, another question is, what's the role of naloxone in acute opioid prescribing or in post-surgical opioid prescribing or in the emergency department, opioid prescribing, all those other settings, and we really haven't addressed that in our model. There may be other work out there that's being done on that. So, any other? Yeah.
I had a question about the Narcan nasal spray.
Yeah.
So on the back it says that you have to keep it in a temperature range of like 44 to 75 degrees, which seems pretty short, or pretty narrow. Do you know if they're doing any studies about extending that, so that they can preserve the effectiveness of the Narcan for people who are experiencing houselessness or living in really warm or really cold environments?
I don't know of any studies, but it certainly probably warrants study. I mean, I think the other issue is, there's other issues that probably warrant evaluation, like, is the expiry date really a real expiry date or not? So I think there's a lot of sort of pharmacy type of studies that probably need to be done, and I don't know who's doing those or who could be doing those, but I think those would be really good. Those are important studies that probably need to be done about the stability. Some of it might have, it was an approved drug in 1971, so there may be very old literature about some of those things. I'm sure that was given to the FDA too, and maybe it's available under like a FOIA or something for the Narcan. There might be some stability studies that were done for the FDA, so that might be available. I just haven't seen it. I don't know it.
I know that there are some. My understanding is there are some studies looking at it, and in terms of Good Samaritan, you can always administer expired naloxone. But for like police departments and stuff like that, they're really struggling because they get these initial grants to stock naloxone or whatever, and then it's expiring, and they don't have like the authority to use various drugs on someone.
Yeah.
So this Monday, CCTSI Director Ron Sokol organized an hour meeting for the UO1 mechanism on opium, and in at least 3 CTSA hub, and also linking with NIDA Clinical Research Network. This aims opportunities for this, if some topics can match with this funding mechanism.
Yeah, I think hopefully there is some way that some of these topics could be matched to that. And it sounds like there's an unlimited number of applications that can go in under that application. So hopefully there will be more work. Oh yeah, Des.
Yeah, I was thinking about the other people in the family, like the children, and I wondered if your Kaiser study, if you're looking, I was just thinking about the case control study and whether you could identify impact on children.
Yeah. So, in my long list of unfunded grants that I alluded to at the beginning has been this ongoing, persistent interest I have in looking at the effects of parental prescribing on children, opioid prescribing on children. And there's been one study, a couple studies, but one in particular that has been published that shows there probably is an impact. And so and we found in our data when we did a preliminary study that 55% of households had been prescribed in the Kaiser system, had been prescribed an opioid in the last 3 years. So there was a lot of household exposure to opioids. And I'm very concerned about that. And I would like to see how, to learn more about that relationship, how it impacts risk for children to sort of, potentially grow up in an environment where there's a lot of opioid use for pain or for whatever, and then also the risks to children in terms of direct exposure. And I feel like as an adult physician, it's our responsibility to tell our patients to lock their medications, but that hasn't been routine. And I don't know how many parents do that. So we haven't really done much with the naloxone in children. Again, I think the outcomes would be very, very rare. So we really would need multiple sites to show a benefit on child overdose, but that is something we could potentially study once we get all this data together from a bunch of different sites. So that's a good idea. I'm going to try to keep that in mind to do that. Let's see, someone, yeah, how about
I was just going to ask if you know the numbers of how many people, or anything that suggests how many people do lock up their opioids, and then how many of those are parents, or how many parents do?
I haven't seen a lot of I haven't done a literature review in the last 2 or 3 years since I gave up on that line of research for a little while because I was so dismayed that nobody wanted to fund it. And so, but I didn't find a lot that described what the rates of safe storage are. I think they're pretty low is my guess. In drug treatment, I do ask patients if they store their buprenorphine safely because I think that's analogous. And my rough anecdotal guess would be that probably 60% of patients tell me they're safely storing it. 60, but that's in a drug treatment setting. And I think safe storage there also is a little loose, like they might be putting it up on a cabinet, but it's not actually locked up. So, but yeah.
So, did your patient come back to you later or no? How you follow up? In
treatment or what? Well, right now I only do addiction treatment. So, yeah, many of them come back, follow up with me. Yeah.
So, so means that you have a cohort of the patient, you follow up the patient.
In treatment. For opiate use disorder. Okay. Yeah. Yeah. Okay. Yeah, we do have some cohort. We do have a cohort of patients in treatment.
Do you have idea how many % of your patient have, say, kidney function, kidney disease?
It's still pretty rare. A lot of our patients are young. They're young, and so we don't have a ton of patients with a lot of comorbidity. I mean, we do have also an older group too, but a lot of them don't. It's overall a relatively young population, but we do have some with some comorbidity, but not a ton. I wouldn't say a lot. So, okay, great. Well, thank you so much. Happy to talk to you.